So, good afternoon, everyone, and it is my pleasure to welcome you all to this interesting session. You would have noticed that I've said good afternoon because we are already ahead of times. So this is digital world, 10 minutes ahead of time, and rightfully so. I think not a day goes by when we do not touch our screens or have not seen our screens. So it is apt that our specialty of orthopedics, which has also not left untouched by this digital revolution, that we talk about that and see how things are moving ahead. What are the newer changes that are happening and how this will impact our practices. It is my pleasure to welcome our chairperson for the session today, Dr. Nikhil Shah and Dr. Allahabadia. It's really a pleasure, sir, to have you here. And our first speaker today is Danny Goel. He's going to deliver his talk virtually, and we have this recorded session. Dipit is here with me. He's the co-convener of the session, and he's taken a lot of pain to ensure that this talk happens. So over to you, Professor Danny Goel, and welcome to this conference of WIROC. You can unmute yourself, and if you want to say a few words before we start your presentation, you're please most welcome to do that. Professor Danny Goel,
thank you.
He's an orthopedic surgeon with specialty interest in VR. His company, Precision OS, is one of the most famous company in this arena, and I'm sure we'll keep hearing about this interesting concept as we go further in our careers. Over to you, sir.
Yeah, thank you for the opportunity to speak. And
Canada.
Are you able to hear me?
Yeah, please go ahead. Sorry.
Oh. Yeah, I just wanted to say thank you for the opportunity to speak, and thank you for taking the trouble to offer me the opportunity to speak at your conference. I hope to be there next year or the next meeting in person, so I hope to visit with you at that time. And please, to stay on time, you may play the recording.
Can we play the recording?
Friends, thank you for this opportunity to speak to you today about virtual reality. I'm honored to be speaking today at WIROC, and I apologize I could not be there today in India, but I hope to meet up with many of you over the years and the coming months. So my name is Danny Goel. I'm an orthopedic surgeon in Vancouver. I focus on shoulder reconstruction, and I'm going to speak to you today about a very exciting topic, specifically virtual reality and accessible education and mentorship. My disclosure here should be noted. I am the CEO and founder of Precision OS, and I'll be sharing some videos of this simulation software platform today in my presentation. So to really understand how VR can actually play a role in what we do, we need to understand the problem in more detail. Around the world, there's 300 million procedures done annually, and of those, 50 million patients suffer complications annually. The expense of this is not insignificant. It costs $1 trillion per year to address surgical complications with revision surgery and other sequelae of prolonged procedures and those from surgeons with inexperience. And Harvard Business Review talks about how do we innovate in an area that's been really cemented in tradition over the years, specifically in musculoskeletal care. Now, when we look at the problem in more detail, and when many of you know Halstead and his theory of see one, do one, teach one, this is an image from several years ago of the first cardiac procedure done in the world. And you can see that there's probably one or two people actually performing the procedure, but many of which are actually watching the surgeon do the procedure. Now, what complicates this even more is our surgical trainees who are graduating. This is a study that was published in 2021 that looks at, of the 90,000 general surgery procedures done in the US in this study, only 1% of those studies or 1% of those procedures were done by residents independently. And this is a really important point because it speaks to the next aspect of this, which is the learning journey of how do we become proficient as surgeons over the years. We know that it's very expensive. We know that it's a significant amount of time commitment, but we need to become more skilled to increase our proficiency and reduce our complications. So effectively, when we're learning a new skill, a new procedure, we end up practicing on our patients as opposed to treating the patients. What's even more interesting here is if you dig into the science of how we learn, we know that people will learn when they need to. That's how we're motivated. If you do not apply a skill that you've learned within 6 days, you will actually forget 75% of that knowledge But the way to mitigate against that is if you do something that's very deliberate, very experiential, actually provides you data and is purposeful, that concept of deliberate practice, which is effectively absent in most of our surgical education, can actually change how you become proficient very quickly and a very cost-effective way. So when we think about virtual reality and we look at the science of learning, how do we merge the two? How do we align the learning science with surgical education today? Now, many of you who may be interested in this concept of disruptive innovation would be interested in the late Clary Christensen, who talks about how do we use disruptive innovation to actually impact healthcare. One of the things that's happened over the years in the last several decades is the benefits of Moore's Law. Now, for those of you who may not know about Moore's Law, computing power doubles every year and the price of that actually decreases over time. And you can see on the far right that we've reached this inflection in medicine where we can actually use certain technologies to help us benefit our patients over the years. So what is immersive virtual reality? So IVR, as it's formally known, refers to a computer-generated simulation where someone can wear this headset, as shown in the illustration on the right, and interact with a completely artificial three-dimensional environment. There's no computer, there's no wires, and this is quite a lightweight headset that rests, as you can see comfortably, on this image on the right. So this next video actually shows you the capabilities of what you can do today in virtual reality. And it's a combination of many things. So not only can we add in the entire patient experience, as you can see here with this shoulder model, I can do things like I can cut the humeral head, and actually it gives me data immediately on what I've done. So I'm allowed to make error, and those of you who know about learning sciences, we make and advance our skill by making mistakes. Here's me with a hip arthroscopy, where I can actually use the C-arm, I can burr the cam lesion, and it will tell me how much of that cam lesion I've actually resected. This I will speak about in the later part of my presentation here, where collaborative learning we know is very powerful. Imagine being in a room with a mentor 3,000, 5,000 miles away and actually learning from them without actually having to leave your home. You can see the environment here is very interactive. It allows us to deepen our understanding of three-dimensional anatomy, which we don't have a really good model of right now unless we're using sawbones and it's actually recreating what we do in the real world. I'll be talking about the literature on this, which we've done extensively to actually prove that we can actually transfer skill in this environment. So one of the studies that was done in a few years ago compared senior trainees who read an article or actually trained in virtual reality and then examined on a cadaver. And you can see here, not only do you learn much more efficiently or faster, you can actually improve your surgical efficiency, enhance your technical skill, and also enhance your knowledge base. Now, if we take it one layer deeper and say, well, what are the reduction in surgical errors that we may see? This is a study comparing senior trainees in VR or watching a video of the same surgical procedure and then testing them on a cadaver published in JAMA. Not only, again, as mentioned, do you learn much more efficiently, you actually reduce your surgical errors dramatically in this particular study. So skill transfer is profoundly known to be an important aspect of validation of a simulation platform. And then, of course, the cost per simulation is a fraction of what it would be to actually fly to a course, practice on a cadaver, and then expect that skill transfer in the operating room. This is some new research that's coming out this year, or in 2023, comparing virtual reality directly to learning on a cadaver, and you can see that the outcomes are actually equal. Not only are you acquiring the same amount of knowledge, your technical skill is equal in both conditions. However, the cost of simulation with virtual reality is at a fraction of the price as it would be if you were to use that same model in a cadaver. How does this directly affect patient care? This is a paper published in the Journal of American Academy, which shows the image on the left treated by a surgeon in practice trying to pin a slipped epiphysis. And you can see the arrow in the red is where he put the implant. Where he should have put the implant was in the green. And this was done after 2 procedures and 200 x-rays. So effectively was unable to understand the three-dimensional anatomy and then be able to do this procedure successfully. When that patient was transferred to the Children's Hospital, the resident who's never done this case before practiced in immersive VR 4 times, which took about 20 minutes. And then actually he performed the procedure by himself independently in a single procedure using 10 times less radiation than the index procedure done by the surgeon who's been in practice. So when we look at this, the impact this can have around the world in terms of affecting the learning journey, we can actually perhaps enhance the learning journey as shown by the literature earlier and this direct patient case I've shown you. So imagine a state where not only can you learn faster at a fraction of the price, where you're actually much more competent and proficient, where your skill is the highest and you can reduce your patient complications. One of the things I mentioned earlier is this concept of remote mentorship. You can be anywhere in the world if you have a headset and the software and interact with your colleagues in a very interactive, authentic way and learn from them. And we do this all the time, and this is why we attend meetings and courses. And this next video actually shows you.
Standard the reaming, the reaming.
And I'll just turn the volume down here, but you can see this is Dr. Warner doing the reaming, Dr. Athwal on the right, and then Dr. Sanchez on the in the background. And they're describing how the impact of metaphyseal reaming in this particular case, which happened to be a shoulder arthroplasty case. And all of them are at their homes, and they're approximately 2,000 to 3,000 miles away cumulatively. So when we look at, in summary, how do we take a very traditional model of learning in surgical education, add an innovation like VR? It's not meant to replace this, but can we augment this significantly to allow us to learn and teach in a much more effective and efficient way? Imagine shortening your learning curve, reducing surgical error, as well as the impact it could have on the cost of medical education, which we know is actually increasing over time. So in summary, one of the things that really excites me about this topic and this technology is that it addresses and can address several of the challenges we're having in education. We all know that education is very complex and multifactorial. This technology is, although very exciting, it's still maturing, and we're going to see a lot of growth in the next 2 to 5 to 7 years. The validation studies that I've shared with you, which have been published, not only show that it's much more efficient to learn this way, it's cost effective, and actually does lead to skill transfer, as we've seen in both cadaver and in direct patient benefit. One of the added values of this technology as well is that there's a lot of new medical devices that are being released annually from multiple different companies and providers. It actually adds a layer of medical device comprehension that we just have not seen up until this point. And with that, I'll summarize, and thank you all again for your time and attention, and I'm happy to answer any questions at the end of this presentation or by email as listed here. Thank you very much, and have a wonderful day.
So any questions from floor? Yeah, please. So we've got Dr. Manish Agarwal here. He wants to ask a question.
That was a very, very good comprehensive insight into what are the possibilities. Now, I'm particularly interested in the surgeons interacting with each other, maybe to develop new techniques or maybe to learn new skills. Is that going to require some specialized software, or just having an Oculus headset with each person who's interacting would be enough to be able to interact on the same model?
So it depends on the level of interaction. So the software that we develop is what I showed there today. So if you have an Oculus headset and access to our software, you can interact and do R&D in this environment. If you're thinking of a new procedure, a new implant, that's all possible in this environment.
Dr. Manish, so we've got something similar we'll be demonstrating here right now for virtual reality. Yeah, sure.
Now, is there a difference between what you can learn between virtual reality as on an Oculus headset versus, say, mixed reality using the Microsoft HoloLens?
The biggest difference is in virtual reality, the environment is completely digital, and you can interact with that. So I pick up a virtual saw and I make a virtual cut or a virtual wire driver, and I can put it into a glenoid or a hip, for example. And what's interesting there is that I can actually then collect data on what I've done. So if I put the pin in, 7 degrees or 10 degrees of version, that data is available to me. Mixed reality, as you know, is an overlay of a digital footprint on top of the real environment, and the interaction is limited. So it's giving you information on your real experience. That's the biggest difference. Can you learn with mixed reality? You certainly can, but it's not as interactive and doesn't capture your decision making like VR does.
No, so the reason I ask this is, what if you had that same model like you have in virtual reality available to you as you are operating, so that you can practice on that model before you actually do the step on the case? Is that going to be possible?
Eventually, because the headsets will be combined into one, meaning that you're going to have virtual reality and mixed reality capabilities in one headset.
Thank you.
Professor Goel, one question for me. How accessible is this technology right now? Do you think?
Very easily accessible. So if you have a headset, it's just downloading software. So it's extremely scalable in that way. The limiting factor is just being able to access the headsets, which are globally available.
Okay. And what modules are available right now? Is it practically for all kind of surgeries, or you are specific to certain things?
No, so we have every aspect of orthopedics covered, from shoulder to spine, trauma, and hip and knee arthroplasty, as well as pediatrics.
Okay. One last question. What was your greatest challenge in getting these things done?
Well, I think the challenges continue, right? Because we're addressing a very conservative industry with a technology that's very cutting edge, it's innovative. And one of the biggest things with VR is that we're unlocking data on how people make decisions. So I don't know if we all understand what 125 degrees of neck shaft angle is, because we've never been able to measure it. So the research applications of this are extremely exciting. And but to your question, what are the challenges? I think they're continuous in this space when you're adding an innovation to a conservative industry like healthcare.
So we've got Dr. Tanna here, and he's asking us, what's an average cost of acquiring these things? So if you wanted to get it here, how easy, difficult, cost perspectives?
So we've made it affordable because we think that one of our missions is to provide accessible medical education and mentorship globally. So depending on the facility, the number of users, the model is based on that. So, that's a discussion I'm happy to have with people who are interested in having this at their institution. Right now, our software is being used in over 70 residency programs around the world, from China or Asia, Latin America, North America.
So one more question, one last question.
Of course.
So do we have a different templates for the deformities on the sawbone models, which are currently being used, like different types of rotator cuff tears or different types of varus deformities during training?
In the virtual reality module?
Yes.
So several of the modules do have different pathologies. So for example, in the slipped epiphysis model, there's a mild, moderate, and severe slip. Some of the shoulder model has different glenoid deformities, and we can continue to add different deformities in that case. What's really important here to note with VR is that if I'm doing a procedure on a sawbone, all I see is the bone. In virtual reality, what we can do there, and what we have done, is that when you're doing, and I'll use the slipped epiphysis case, is you can actually move the hip. So it's on a fracture table, so you can internally, externally rotate it. Use a virtual C-arm, so I can capture how many images you're taking. You can put the pin in wherever you want, and then you can pull the bone out of the body. So it's a much more comprehensive educational experience than just putting a guide pin in a bone, in a sawbone, as an example.
Okay. Thank you so much.
Thank you, Professor Goel. Thank you for such an interactive session. And we continue the journey with some homegrown talent here. We'll continue the VR environment. So please stay back if you can, and we'll love to have your inputs as well. So we have Dipit, you'll be going next, yeah? So Dipit will be talking about the Geo Glass and the VR and AR in the operating room.
Yep.
Is there a way to see the presentations? Because I can't see the presentations where I am.
Yeah, I think so. We can, this will be focused here. Can we transmit it?
Yeah, so that was a very comprehensive talk. And
are you able to see the presentation now?
I can, yes, thank you.
Okay, thank you.
So we've collaborated with George Athwal, and I am in talks with him, and he is using virtual reality in the operating room. This since the last 1 year has exploded in shoulder surgery in UK, US, France. Some of my colleagues are using it on a regular basis. In shoulder replacement surgery, which is the most common use of virtual reality. And we've got something to demonstrate here how to use it. Basically, I was new a couple of weeks back, what is virtual, augmented and mixed? I asked my kids, do you know the difference? They are 10-year-old. They did know. I did not know. Does anyone know the difference between virtual, augmented and mixed reality? All the three, of course. So, so virtual reality, you are taken in a virtual world, you see an object virtually. That's it. Okay, so that is a virtual reality. There is no physical world. Augmented reality, when you have a physical world in front of you, it's also visible, and the virtual object is visible or placed in the virtual world. That is augmented reality, which is very commonly used. Mixed reality, this is very exciting. Mixed reality, the virtual object is interacting with your physical space. Means you want to keep my scapula somewhere, it will interact and it will keep it right on top of it or something. So the best part is the mixed reality, which is being used in certain ways in shoulder arthroplasty, the most common use. And basically what it involves is you do a CT scan, then you do a pre-op planning for where the glenoid wire or where your humeral osteotomy has to happen. So you do this pre-op planning. Now you can translate it to surgery by one of the two ways. So most common now what we do or what most people do is patient-specific instrumentation guides. So you get the guide made, you bring it over, it costs a lot, 4 weeks, 3 weeks, loss of time. So this is really very advanced. The entire plan is transferred to your virtual reality glass. You can see that plan intra-op. What that involves is, most commonly, this is the most common error we do. We can do placing a wrong guide plane in a wrong position, and then the whole surgery goes haywire, because there are very deformed glenoids that we get. And this requires some pre-op planning on how to put it exactly in the right place. And we collaborated, so right now with GeoGlass, so this is all the Geo world here, so I thought why not have the same ecosystem. GeoGlass, which is GeoTesseract, is a company, and they are making virtual reality glasses. And so we spoke to them, and Mr. Nitin is here, so we got the glass here just to demonstrate you. What we did was I got a scapula, and then we got the scapula converted into a virtual reality software, so we can see it on the, so can we have the glass, Nitin? So Nitin is here. So this is the GeoGlass where I'm able to see the scapula. So it's not exactly there, means I have to use the phone, but if I have hand gestures, I can rotate the scapula as I want. Now, this was my biggest worry. It should play when it matters the most. So we've been trying since last night.
Just reload it once on the laptop. It'll work.
Reload it.
Because it's working here.
But more important is you can see it. No?
So I can see it very well. So scapula is right in front of me. And
At least you can protect.
so it should move. Now I have a backup plan ready though. But it should move. And yeah, I can see the scapula very well. It's rotating. I can move it around. I can zoom it in. It's probably not happening here. And this was the biggest worry yesterday. So I'll just show you what I was going to see. This thing. So this is how it moves. Now this is virtual reality, it's not augmented, the physical space, he took it away. So but this is the scapula, we'll move, zoom, rotate, and right now we don't have the hand gestures, but we should have, and we should be able to see pointers or the pre-op planning in the scapula and in the glenoid, where to put the pin. So for example, this blue line that you're seeing, we'll have something similar which will tell me where to put the pin, which angle. I'll put this scapula right in front of me in the surgical field on the real scapula. because I'm just seeing the glenoid. So I'll match the glenoid, and I'll be able to see where I have to make the glenoid central hole, where I have to do the humeral osteotomy. So this is what is happening on a regular basis now in Western countries, and this is what we are planning to get it here also. So we are collaborating with GeoGlass. Just wanted to demonstrate you what exactly lies in future, and this is not very far away, because as I've seen, this all happened in probably 1.5 years space. That's it. Started maybe 2000 late, and now what I'm hearing is some of my colleagues told me just last week, we just use twice. We are using it once or twice every week. They are using the virtual reality in shoulder replacement quite regularly, and not very inaccessible also. So the companies have to scale it up. For example, the implant companies and all. Multiple papers coming out, as you know. As soon as the new technology comes in, the feasibility, the accuracy starts getting published. So we are already having that it is actually not inferior to the patient-specific instrumentation guide, and much cheaper, more feasible, more readily available, and much more easier to do. So already many publications coming in. Summary, I think it is revolutionizing the shoulder arthroplasty. Maybe we are planning to get it as soon as possible for our cases as well, maybe next year. And robotics may be one of the next steps after this, along with mixed reality. Thank you. Thank you, Nikhil.
So thank you, Dipit. Any questions for Dipit? Yeah. We've got Dr. Manish again here.
Dipit, question for you only. Now, I believe the biggest challenge in overlapping the bone model which you have created in virtual reality or mixed reality with the actual patient is the accuracy. I mean, how do you ensure that the bone model is accurate on that and that the angle that it is showing you is perfect? I mean, do you have any markers that you put on the real scapula to match the bony points and tell you the accuracy?
Yeah. So that is the very basis and very basic, going into very basic, because if that goes haywire, the entire execution of the plan goes haywire. So just as in patient-specific instrumentation guide, you have 3 points matching. So you put the guide. So exactly here, there will be, like for example, in scapula, I can tell you it's matching the coracoid, matching the glenoid top and inferior part, and then it should align because it is mixed reality. It should interact and align itself, place it exactly there, and show me the markers. So I have actually, we should be able to do it pre-op in a computer or even in a glass, and that same plan should be available to me in the operating room. So I'm able to see where is the planning, what exactly is the planning. I'm not able to, I should not be going back and forth. I should be able to see the exact planning which I did before the surgery, and I see my markers, my cutting angles, my osteotomy site, my osteotomy angles. So exactly that should be available, but the scapula and everything should be accurately placed is what depends on the software and the company, but they are able to do a good job outside, because that is what I've read in the publications, that the accuracy done in cadavers, tested in cadavers, is very, very accurate.
No, because during the surgery,
yeah,
our actual bone can move.
Correct.
And if it moves, does the software model move with it? I mean, do you have the software which will move with it and account for that? Because otherwise, as you are drilling, that movement can translate into a wrong angle.
Yeah, those are very specific questions, sir. Maybe I won't be able to answer this right now. Very specific
I can
questions.
answer that. So,
yeah.
No, so
they are using it, the software is enabled by the pharma company. For example, Stryker. So Stryker has its own pre-op planning software. They are getting their own HoloLens, Microsoft HoloLens. So they've incorporated the entire thing, the pre-op planning software as well as the HoloLens in one. So they go from zero to end. Everything is one go. Their pre-op planning, their HoloLens, their execution, it's all in one go. So they are very accurate. Their HoloLens and their pre-op, it's called the Blueprint software. It's kind of very accurate. The Blueprint was pre-existing. A couple of years. We were using it. I mean, when I was there, I was using it. It is one of the most accurate softwares. Now, HoloLens is incorporated into Blueprint. So it is now mixed reality Blueprint softwares. So quite accurate, as they say. And some of the people are using it very, very regularly.
So,
And this reality, what difference would be to the results of that? Is there any
Differences in millimeter, even in the expert of hats, there could be millimeters of difference if you're not using any guides. Means if you're using free hand, even the experts can go wrong. And it's a matter of few millimeters in shoulder replacement. Everything goes haywire if few millimeter is off.
I'll answer that. Tanna sir got made in 40 years. Now we are looking at 4 years. so I think, no, but see, but not everyone can be Dr. Tanna. So I think that's what the technology does. It adds to the precision. To your point, sir, I think what it does is it identifies certain landmarks that you have to check. The same with the robotics. When you do that, it is basically overlaying a model over an existing thing. And for it, it's like tracing a paper. If you are tracing a paper, you need points to match. So there are 4 or 5 points that you need to align to it. And irrespective of where they move, they'll get aligned to that particular point. So if you've got 4 in different directions, and for each bone it is different. For example, knee, it could be a medial epicondyle, it could be an axis that you define, and the model is overlaid according to that. So even if there is the slightest movement, no 2 point can match. And the moment it is done, that means that there is an error. For example, if I've done medial and lateral condyle, and there's a tilt, both medial and lateral condyle will not be same from what I have marked. If there's slightest tilt. So at all times, it will align itself to at least 6 to 8 different points, and that tracing has to match exactly with the anatomy, irrespective of where it is in the space. And of course, then there are additional things like checkpoints that you put in when we do robotics to ensure that, okay, your whole system has not gone haywire. But with this, you don't even need a checkpoint because you've got those 8 things. As long as the tracing is exactly mapped to that bone, it will work. Otherwise, it will give an error, okay, I want you to redefine those points and then map it and overlay over it. So I think that's how it is. It's real time. As far as I believe, it is available right in this place at this moment. So we've got a VR zone, right, Dipit? I believe we've got a VR zone set up here. Most companies now have it in their portfolio. Smith & Nephew has it. I think Depew has it. Synthes has it. So, and they've got almost all their products. So it is of course commercially driven, so they will do it for their products. For example, there's robotics. So there is a robotic software available where you can practice it on this. There are available for meniscal repair. So Smith & Nephew has a meniscal repair module where you can practice it. I don't know which modules they have here because I have not visited personally, but I'm sure that for at least sports medicine and arthroplasty and a lot of trauma things, it is available. It is available, and I think VR zone is here, and I would encourage every one of you to go to that VR zone and experience it firsthand. In this conference. Dipit, you have an idea of which hall it is or where they've got? But yeah, so passage next to hall A and B, people can witness it firsthand. Okay. So thank you. I think we are running short of time, so we'll go ahead and I'll try to quickly.
We have only 20 minutes for 6 speakers.
So we'll rush. Yes. Okay. So we had a lot of interesting things. So we'll do it very quickly now. So we have had a very interesting talk on VR. We move on to a next thing, which is in reality right now. It's not virtual reality. The reality of robotics is here with us, and we know what success takes. I think its success is like solving a crossword puzzle, and the key pieces are technique, technology, teamwork, and talent. As I said, not everyone can be Dr. Tanna, but we all have our own talent. We need to just identify that. We know the shift is happening. We have seen all the shift happening with a lot of things here, teaching, and all the things that we witnessed here is there. And we also know that there is scope of improvement in everything that we do. We all feel that we are the greatest surgeons of all time. We are all Messis, but we are not Messis. We know that we can improvise better, and that is why there is a scope of improvement. As an arthroplasty surgeon, I am cognizant that not all my arthroplasty surgeons do well. And they do not do well for some reasons that we know. And I think there is a scope of improvement, and that's where the robot comes. We have seen robot in almost all industries, but when we talk about robot in medicine, they are not same. They have common roots, but do not share the same rationale. In industrial world, robot tends to replace people, but I think here it will augment our intelligence and augment our skills as we go forward. It has evolved over time from balancing tool to surgical guides, and they are like Siams. in earlier time, I used to remember my KM days where people used to put, I can put central wire without any X-rays, and we had legends of people working today. But today, it will be considered foolishness. And I think robotics is like that. I think over years, people will have say that people were great and they could balance and they can do all the cuts. But today, if people do it, or in coming 5 years, mark my word, in the coming 5 years, if people do it without technology, it will be considered something as non-exotic, or it will be considered that you are not doing something right. Different type of robots are there. I will not go in detail because of time constraints. Of course, I talk more about arthroplasty, being an arthroplastic surgeon. These are the mechanical goal. When we look at it, we restore alignment, we preserve or restore joint line, balance the knee, precise component alignment. We do have additional goals in terms of minimizing the surgical time, decrease infection, reduce pain, reduce stay. Ultimately, we want happy surgeon and happy team and a cost-effective world. There are key techniques. We all know that to execute a TKR, we need all these things in order. And we also know that we have changed over time. So our philosophies have changed and they keep changing. And when we look specifically at total knee replacement, we have moved from what was sacrosanct holy grail of mechanical alignment to anatomical, kinematic, restricted kinematics. But today is the era of an intelligent alignment. And I call that intelligent alignment because we have got technology to tell us where to go. Our experience, our expertise is combined with real data which is on board to make decisions. We all want to be accurate and precise, but there are few of us who are very good at execution, but they do not know where to go. They are not accurate but precise. There are people who know where to go, but they are not able to execute it well. And there are certain small outliers who do not know where to go and cannot execute well. You will, of course, traditionally we were taught to be accurate and precise, but technology has told us that goalposts are changing, and that for every patient the goal is different. And today we are dealing with different patients with moving target, and that's crucial because robotics gives us a chance to tell us and tailor makes it to each patient. And we know when we look at our balancing in this, it's ability to juggle different planes, 6 planes of translation and 6 movement. If we understand this, you are a good arthroplastic surgeon. And together they make 955 permutation combination, and you have to execute it in few seconds. And that's what robot does. With experience and expertise, you are here, but with technology, I think we make our way closer to the bullseye, and it's different for different patients. The million-dollar questions, we are in a technology world, will they replace us and should they replace us? And I just leave it with this interesting thought process. Yes, they will outshine us. But as I said, will they replace us? I don't think so. Because in the very end, there are important things that we need to consider. They're outpacing us in every aspect. But eventually, it will matter only if you can enjoy it. So any change is only when you can enjoy it, and I think robotic is the time. I thank you for your attention, and just leave it with one comment. The best way to predict future is to create it. And in this room, I can see that we are all digital enthusiasts, and you've seen Dipit giving a brilliant presentation of a homegrown technology of GeoGlass. We had a few moments of laugh, but I think it is important for us to participate in this revolution. I invite you all to encourage and do much more than what we can. Thank you, everyone.
Dipit, you have a lecture? No, you're done. Taufiq, Panjwani. Wearables to monitor the patient post-op.
A very good afternoon, and I'm sure everybody's hungry, so we'll start without further ado. These are my disclosures. I'm an orthopedic surgeon with the co-founder of Recover Right. This was 2007. I'm sure a lot of people remember this. This is the first iPhone that Steve Jobs introduced. And this is where we are 15 years down the line. 84% of the world is connected and is reachable on a single click. Apple has sold 2.2 billion iPhones already. So in the last 15 years, we've changed by leaps and bounds, little bit every day. And in 15 years, we find it to be completely, the world around us is completely different than what it was. Not just our smartphones, our cars, the electric bulbs, the air conditions, even the bulbs in our bathrooms are connected via the internet and can be operated from anywhere across the world. So this is what we are talking about, a connected world. Currently, there are about 12 billion connected devices, so about 2 per living entity on this earth. In about 5 years' time, we will have at least 3 per living entity around this world, connected devices around the world. So as the world is changing, as the technology is changing, our patients are also changing. And earlier, arrhythmias were detected on ECGs. Now it's available on an Apple Watch on demand. A lot of people now have a dermal implant for continuous glucose monitoring. Earlier we used to do HbA1c and FBS and PLBS, but now it is out of fashion. And this is what our patients are already doing. And it's not just our patients, our lifestyles also changed. I don't remember, taking a Kali Pili taxi in a few years now, in about a couple of years now. Food is on delivery always. And the way we interact, the way we talk to each other, as well as the way we transact and transfer money to a chai wala is also changed. But our post-op rehab is still in 1990s. We still hand out printed post-operative physiotherapy instructions, and the physiotherapy is visiting the home every now and then to check on the patient and how the patient is doing. And we are late to the party, but last 3 years we've been just scratching the surface in terms of what can we do in terms of post-operative rehab for our patients. So this is a study published in Journal of Arthroplasty in 2019. It's a pilot study of 25 patients in which post-operative after total knee replacement surgery, patients were given sensors, a sleeve with sensors on the knee, and they were asked to go home and do physiotherapy. And these patients are remotely monitored. So remotely monitored for their activity profile, knee range of motion, opioid use, as well as exercise compliance. The interesting part about this study is that 22 out of 25 patients found that the system was motivating and engaging. So they were more engaging with the healthcare team. Similarly, for hip arthroplasty, there's another study. I'll leave that for the interest of time. So what are the current challenges in post-operative care that we are facing? So once the patient is discharged from the hospital, most of the times we don't know what is happening with the patient. And this is the most important phase of the recovery of the patient, which is in the dark zone. The only point in time when we know anything of what is happening to the patient is that when they call us or visit our emergency departments, and that is the time that we know what is happening with the patients. Also, the current rehab and the physiotherapy is at best, intermittent. The physiotherapist may visit once a day, maybe once in 2 days, and the patient has the patient has to go to the physiotherapy center, which is again time consuming and costly. Also, we take patient-related outcome measures. Scoring systems are at best intermittent outcomes of recovery. We don't really measure what is happening throughout the process of recovery. And in all this process, there is no way to engage the patient. There's no biofeedback which is happening. So what are the current wearables that are being introduced for total knee arthroplasty? And Zimmer has collaborated with Apple. So two giants have collaborated and brought out this My Mobility app. So they have connected all the patients post-operatively. They've given them an Apple Watch and sent them home. And the Apple Watch really calculates how they are doing in terms of recovery, rehab, activity profile of the patient. And this is a study that they published in 2021 in which they found that there was no difference in the readmission rates and the clinical outcomes of the patient at 3 months out post-operatively. They compared formal physiotherapy with smartphone-based care management. But interestingly, the patients who were on the smartphone needed less physiotherapy, had fewer emergency department visits. So effectively, the cost of the treatment, cost of the treatment went down, and there was better patient engagement with the healthcare team. Similarly, for total hip arthroplasty, so now the interesting part is that the outcome measures will have to change. So we need to move from PROMs to PCOMs, that is passively collected outcome measures. The patients will really have to fill out those forms, and it's a tedious process, and therefore there's a lot of problems in filling out those forms. If we have a sensor on the patient doesn't have to do anything. The outcome of the patient is measured directly, and we get all the data 24 hours from the patient in terms of how they are recovering from the surgery. And now sensors have also, so this is also an interesting interesting thing in sensors on the foot soles, which can measure the biomechanics of the patient. The gait analysis of the patient post-surgery also can give us a lot of data. So
Taufiq, I think we're running out of time.
Yeah, I'll conclude in a minute. So let's come to India. In India, we are also just scratching the surface last 1 year, and we are developing a smart knee sleeve with sensors, and we'll be giving it to patients. We are starting beta testing for the same, and we'll be giving it to patients, and the patients will wear those, and we can calculate the steps, the pain score, exercise compliance, the knee range of motion without actually seeing the patient. So patient can be 1,000 kilometers away from you, but we can access all this data just with the help of a knee sensor. So that's where we are. I think the future is ability to collect data. If we have adequate data of how the patient is doing, I think we should be able to do more, we will have better insights of the patient, and we'll be able to intervene at an appropriate time. Real-time feedback with all of these data can be put into machine learning algorithms, and then we can actually stratify the patients which actually require more help post-operatively, right? Say, for example, if the patient is doing well, you're not too worried about the patient. But if the patient is not really up to the mark, we can actually intervene at an early stage and identify those patients and treat them accordingly. All of this is to, with a single point agenda to improve outcomes and to reduce the cost. I think. Thank you.
Thank you. I'd like to invite Mangal for his next talk, Planning Tools for Orthopedic Surgeons.
Okay, so I will kind of jump right into it. This is how we used to plan earlier with paper tracing. Some of us then graduated to using various forms of PAC systems or something like TraumaCAD, which is a two-dimensional software where you can plan on the AP as well as the lateral. And for this kind of a patient where we wanted to do, say, for example, Elizarov, once you've planned the correction, then you put on your frame, what is going to be the size, location of the hinges, what's the length that's going to connect, etc. That can be done. However, now what we've got is three-dimensional software where we can take 2D X-rays, that's an AP and a lateral, along with some markers, or in more difficult cases, we can use the CT scan directly, and then that is converted into a 3D model, which then goes into this software. Using this software, you can then, surgeon himself can play around with it, AP, lateral, axial view. This is from a CT, and I can show or hide all the other parts to focus on that. So in this particular patient, we are focusing on the tibia because that's the deformity. And just like any other software, without measuring, there are ways of putting the magnification factor and all that. With a CT, that's not required, and you get all the angles that you want, which we commonly use for lower limb deformity correction in terms of the LDFA, MPTA, etc. So here we'll hide the femur. Now we are only on the tibia, looking for all the deformities. Just like we draw axes on the proximal and the distal fragment using pen and paper, these axes can be drawn. You can move this around either in a continuous thing or by using those markers, AP, lateral and transverse, you can move that. You can change the angle, and if you look at the lower left corner, that shows you what angle is being formed with the joint line. There are multiple modules there where you can do an HTO, distal femur osteotomy, or a complex deformity like this. So there are two osteotomies, they are shown. All the data about those osteotomies comes up on the right. You can do an open wedge, closed wedge. So basically whatever you want to do, you can do it digitally. You can make an oblique osteotomy over there, etc. Once you do that, you can then simulate. So planning you can still do on 2D, but the problem is in terms of simulation, especially when you have oblique plane deformities. So after the correction, how this is going to look is seen on the image, as well as you get the numbers as to, for comparison pre and post-op, what were the numbers including the length, etc. Also you can look at the axis. So for example, here you can see the HKA has gone from 168 to 180. That's the goal of this surgery, to make this leg straight. If you want to increase or decrease, you can increase that angular correction, decrease the angular correction. You can add torsional correction onto this model and see how those numbers change. Once you are sort of happy with that, you can then go to implant. And this software supports, I'm showing you right now, I'm showing you the Elizarov, but it supports a rail fixator, it supports internal fixation with a plate, internal fixation with a nail. And so here now I can virtually place my ring fixator into that, onto that corrected position, right? So all the rings are parallel, etc. The other parameters, like what is the size of the ring, all of that can be changed on this. And this tells me what are the lengths that need to be used. And finally then, so this comes to surgery. So this is a simple way of pre-constructing the frame. So now I've got a bent frame which will go onto the bent leg with all the numbers, and that can go onto the patient in terms of that deformity correction. So that was the deformity that was planned. That was the frame that was made, put on the patient, and finally corrected. So in the interest of time, there are other examples. So we have tomorrow in Hall B at 4 o'clock, I will show you how we plan this and execute this using plates for deformity correction. Thank you.
Thank you. I think we end the session now. It was one of the most exciting sessions of WIROC 2022. There's just one thing that worries me. With so much technology coming in, our residents should not jump onto technology straight away. They should learn the things the normal way, get used to it, get expertise in it, and then jump onto technology. For the experienced surgeons, this is the way ahead. One more talk.
Yeah, so we have one more last talk. Sorry for this. No, we still have 7-6 minutes. No? Yeah. So, sorry about that.
Sorry about the confusion. One more talk.
Right. Thank you very much. And allow me to summarize then, because we are short of time. So what the future holds for us, definitely a lot. The top 10 trends which you will be seeing in the next year or so: 3-dimensional imaging with O-arms coming in our operating rooms. That is the future of orthopedics.
Yes, 3 necessary steps to prepare.
Office 3D printing. Can you just switch off the audio, please? Virtual training, which is going to happen, which was spoken about. That is the next trend coming in.
All they have
Augmented
to do
realities.
during
Can you please
surgery-
switch off the audio? Augmented reality for complex surgeries in 3-dimensional deformities is the next trend. Remote patient monitoring, which is a big thing, wherein you will be able to monitor a patient from your home, pre-op and post-op after doing a surgery. Bone substitutes, again, we are having a lot of cases nowadays, challenging cases, wherein you do not get the normal bone of the patient, where gels, substrates, sponges, pastes and powders may be required. Magnetic micrometry, wherein you embed certain magnetic beads inside a prosthetic stump in the muscle, which actually gives a feedback to the prosthesis to function like a normal foot with more than 6 degrees of movement. Seamless rehab exoskeletons is a new technology wherein the paraplegics are going to walk, and people who have long-standing hemiplegia or monoplegia will be able to move their extremities, their normal extremities, with the help of an exoskeleton. Implant tagging, wherein tags will be placed inside total joint implants, which will give information not only about the placement of implants, but also about wears and infections, if at all they are there. And of course, the robots have arrived. You can see 4 to 5 workshops here. So that essentially is what the future holds. So what is the future? The future is about big data. It is about virtual learning, augmented reality. It's about blockchain, and most importantly, robotics, which is coming in a big way. It is also about not competition, but trying to collaborate. The final thoughts is that with so much of technology which we are inventing, are we going to invent new surgeries? Thank you. This is Master Shifu.
You should have come in the middle. मतलब ये बिना दाढ़ी, थोड़ा दाढ़ी आ गया और फिर बाद में पूरा दाढ़ी आ गया.
So this person sells vintage comic books in Malaysia, Kuala Lumpur. Thank you.